I wanted to talk sort of about sort of a philosophical thing about areas of, last year I talked about cohorts. I want to talk about the placebo because in my mind, if you understand what placebo means, it is one of the most powerful therapeutic tools or concepts to know about it. So I'm sure you've all heard of the placebo, and I love these quotes. The history of medical treatment can be characterized largely as the history of the placebo effect. Doesn't sound too great for us, and it's the most studied medication ever, if you think about it. And it always does way better than we thought. I think if you want to be a really smart person, kind of like some of these people, if you understand and appreciate the placebo effect and the placebo response, not necessarily the placebo effect, it's a really useful concept to put into context. As you know, there's all sorts of placebos that you can find. These are some of the images that you can find. And when I first started practicing, I was working in Cranbrook, and we used to dispense Obacalp. How many here, just with a show of hands, have ever dispensed Obacalp? Am I the only one? God. Doug Danforth, come on. You must have. But, yeah?
I just have to add this, that I'm a pharmacist, I work in the U.S., but I've worked with an older guy, and he used to dump the Delmine with lactose in.
Yeah.
Sometimes he wouldn't tell the person, but he knew that this was a problem. And he would come in and say, "Hey, Bill, I'm one of them Delmine Placebos."
Placebos. Yeah. But we would actually, this is in our extended care home, we would spell it backwards so that it'd be, what have you got for insomnia? Oh, Obacalp. What about your anxiety? Oh, Obacalp's really good. There are some ethics issues, but you can actually buy these products. And not only do we have placebo pills, I don't know if you know this, there's a fair amount of research that looks at placebo surgery. One of the first placebo surgeries that was done was they thought that if you ligated the thoracic artery, that would improve angina, because when they did that to some people, a bunch of them got better. But they did really a small trial, but it was published in the New England Journal of Medicine, showing that whether you did it or not, they just did a skin incision and didn't tell them that they didn't do it, the actual surgery, and then there was no difference in outcome. Now, it's a very small number of patients, so you could argue that they missed something. But this has been done in a variety of studies. One of the more recent ones was where they looked at the impact of doing a partial meniscectomy for a meniscal tear. And this is a surgery that was being done hundreds of thousands of times in the States. And they randomized people to actually sham surgery, where they did everything but that thing that they were studying. And again, showed no difference in symptoms or knee pain over 12 months. So it's really important that we do these trials to show whether or not it is better than placebo. Placebo is an inert substance that provokes perceived benefits. That's how we define placebo, but I'm going to get you to think about it in a different way. And obviously there's a nocebo, and the only difference between a placebo and a nocebo, it's something you didn't want. And as you can probably imagine, what's really interesting about nocebo, that things that cause nocebo, they cause things that we all get. I remember looking at a clinical trial that was a 5-year trial, and I think it was one of the fish oil studies, and they captured all the side effects, and one of the side effects was diarrhea. It was a 5-year trial. What does that mean when there's a 15% incidence of diarrhea? It should be 100%, should it not, over 5 years, you'd have thought? But because all of these things happen to us, regardless of whether we're taking medications, you see a lot of these things. We actually use a lot of inert placebos in practice. 77% of the surveyed physicians prescribe placebo at least once a week. However, their definition was it's an impure placebo. So they were talking about things that don't work. Colace, most vitamins, homeopathic remedies, and all that sort of stuff. The number of people who are actually using placebo, I think, was about 1%. So if you understand placebo, it helps you figure out if you should try a medication. It helps you decide whether you should be starting with low or very low doses, and it also will really help you figure out if what I just did, is it the medication? Because as we showed you in some of those examples that Mike and I were talking about, the medication had an effect, but a good portion of the people just got better. And it's a great way to empower patients to help you figure out if the medication is working, because you can say, I'm thrilled that you got better, might not have been the medication. One of the problems that we've had in the area of placebo is this guy. He published an article in 1955, and it is the most frequently cited paper on placebo, about 2,900 citations. And whenever you've heard that the placebo effect is about 30%, 30 to 40%, it comes from this paper. The problem is this paper is not good at all. And that's an under-exaggeration. He claimed that 35% of about 1,000 patients in 15 studies were relieved by placebo, and this is primarily pain. The problem is, and people have gone back and looked at this study, and these are their quotes, for 14 out of the 15 trial publications, they overall found that none of the trials was there any reason to assume the existence of the slightest placebo effect when they looked at it. And in fact, they said it's fully plausible that you could easily explain any of the things that he was showing as the placebo effect as just the sort of the natural history. And even the authors of the papers that he was looking at said there were no placebo effects. So it is the most quoted paper on placebo, and it's where we get the information that it's about a 30% reduction. And not only that, he got a bit confused. He misquoted a bunch of the papers, and he talked about the percentage of patients when it was really the number of pills. So he didn't do a great job of looking at this data. And this figure is what really, a number of years ago, I was of the belief that there was a 35% placebo effect. And this picture that came out of the BMJ a number of years ago really helped me think this one through. And the thing to think about it is, if you do no treatment, that's the only way you can figure out if there's a true placebo effect, is to give a placebo and compare it to a no treatment arm. And that no treatment arm has all sorts of things going on for it. A thing called the Hawthorne effect. I'll show you what regression to the mean means and all that sort of stuff. And that's actually a big part of what happens to patients when we treat them. The placebo effect is that bit that's added on to that, and we'll talk about whether that actually has an effect. And then why we give the medication is, so that's what I call the placebo group effect. It's not the placebo effect, it's the number of people who will get better on placebo, and then above that is the treatment effect. So that's, when we talk about does a drug work, that's what we're talking about. And it's really important to distinguish between that, because I'm going to tell you there's not much of a placebo effect, but boy, is placebo ever useful. One of the things that happens is that regression to the mean, and this is kind of it always makes me smile that this is probably what we see a lot of. So you could graph any sort of medical condition, pain, blood pressure, lab values, they all do this, right? They go up and down, and sometimes it's better and sometimes it's worse. They never come and see you when they're like this, are they? And so if they came in to see you then, you would probably do nothing but make them worse. But they come in and see you there, and they're almost for sure going to get better. And that's a really powerful tool that we can actually use. So if it's bad, it'll likely get better, and if it's good, it'll likely get worse. So it's important to remember those things when we're doing that sort of process. So what Henry Beecher was talking about was it's likely about 35% of people will get better in that placebo group effect. That's what we're talking about. And so and you can use that a lot. So is there really a placebo effect? Well, this is a meta-analysis from about 12 years ago, where they looked at a number of trials, just over 200 of placebo versus no treatment. 60 different clinical conditions, and they looked at binary outcomes, and they found that there was an effect with it, but no statistical effect in conditions that were investigated by 3 or more trials. So this is probably some form of a publication bias where you can find a trial that actually shows it has a benefit. But that's when they looked at binary outcomes. And when they looked at continuous outcomes, they were actually able to show that there is likely a placebo effect. And we're talking about, like, for instance, with pain, maybe a half to maybe 1 point on a 10-point scale. And I'm not trying to scoff at that. That's an important, likely a clinically important benefit. And they've been able to show some of those things in pain, a little bit in nausea, some in phobia. But that's about it. Most of the rest of the medical conditions, we don't have evidence that there's a benefit above no treatment, there is no placebo effect. And you consistently see that, likely with pain, you are seeing some placebo effect when you when you just say we're giving you something that should work. There's a lot of it depends on whether you look at objective outcomes or subjective outcomes. This is a really cool trial where they actually used active albuterol or salbutamol versus placebo, sham acupuncture, or no intervention in asthma. And they were able to show that if you just did something, there was a placebo effect. You can see that the impact on subjective outcomes, albuterol and placebo and sham acupuncture were about the same. But in no intervention, their symptoms did not improve nearly as much. But when they looked at an objective outcome, they were not able to show that the placebo or the sham acupuncture did anything. And we can use that we can work on subjective outcomes even if objective outcomes don't change as much, because ultimately it's the subjective outcomes that patients really care about. There have been a few things that have actually looked at open label placebos. I've always wondered about this. But there is some evidence that you just say, I'm going to give you a placebo, because it's the most studied medication ever and works in almost everything we've tried. And when you do that, it actually, in some medical conditions, allergic rhinitis, some pain things, there is a suggestion that even just doing that has an effect. So I'm not trying to say that there isn't a placebo effect, but it's relatively small for almost all the conditions that you treat. So I don't know why I would ever, has anybody done this in their practice with open label placebos? In Germany, yeah. We don't do that much in North America for that sort of thing, but I've seen it done in a couple of cases. But we don't. We use a lot of things that don't work, which is basically the placebo. But I think there are ways to get away from using open label placebos, and I'll talk about that. Have you ever heard that the color of the drug is really important? Have you heard that before? Yeah, that's not true either. And it all comes from really bad reporting and looking at studies, and it's why it's important for people to look at how we look at this. The only article that's looked at all of looked at all the studies of the effect of color of drugs on their effectiveness was published in the BMJ in 1996. And their authors' conclusions was the available evidence suggests that green and blue may have more sedative effects and red and orange may have more stimulant effects. And it's been cited 400 frickin' times. And the typical comment is, the typical finding that has emerged from much of the previous research is that changing the color of a medicine can indeed influence perceived efficacy. They didn't look at the studies that they reported, so I just went back and looked at some of them. The first one, and by the way, there's not been a study that's looked at this since 1978. That, I'd only just graduated high school then. And you're going, boy, that was a long time ago. The first one was an article in Japanese, so I couldn't actually critique it, but they found, I don't even know if they did statistics on it, they said 79% of patients experienced adequate pain relief with a red tablet, whereas it was 73% of patients with white tablets. There was another study that looked at anxiety of different colors of oxazepam, and the difference did not reach statistical significance. And then, of course, when it doesn't reach statistical significance, what do you say? There was a trend. There was another study that looked at people awaiting surgery where they gave them an orange or a blue placebo, and they were unable to show any difference in sleep. There was another one. This is the only study that actually showed that there was any difference. And then what they did is they took 100 medical students, and they were told they were either getting a stimulant or a sedative. And they were able to show that whether it was a pink or blue capsule, people felt either less or more drowsy depending on the color. But this is the only study that really showed any difference. And it could, again, if you've only got one study, you probably don't have evidence that something really does work. There's been a number of other groups that have looked at this. They looked at analgesics for arthritis, and they were able to, this was an interesting one because they had a real drug and a placebo and changed the colors of all of them. And there was no effect of the color if it was a drug, but there was somewhat of an effect if it was the placebo. So even that is tricky to tease out. And then there was the most recent one in 1978 was an Italian trial, and they looked at whether they used hepabarbital, which you probably know actually does work for insomnia. It's got a few side effects. But they looked at whether they used orange or blue, and they were not able to show a difference in the numbers of people who had a good sleep or an unsatisfactory sleep. But when they asked them the question, how long did it take them to fall asleep and how long did they stay asleep? I've always wondered, how do you know how long it took you to go to sleep? I don't think that's a legit, I think you can probably do it in a sleep lab, but I don't know how you do it there. So that was the only thing that they found. So that is all the evidence we have for the different colors of medications. The proof that colors of medications make no difference comes, well, actually, I've got to do one more slide. What was funny is if you have a belief about something, you can find someone, this guy, who, I'm going to tell you why blue sleeping tablets are better than other ones. And this is what he said. In a series of experiments in Italy, that was the very last one I showed you, blue sleeping tablets or blue placebos work better than tablets of other colors for Italian women. But interestingly, blue tablets tended to have a stimulating effect on men. That was what they kind of found, okay? And he wondered, why is that? Checking with an Italian-American anthropologist college, we came up with this speculation. Many Italian women have a special relationship with the Virgin, who is in Roman Catholic tradition the protector of women in religious art. The Virgin Mary is almost always shown in blue. So that's why it's a calming effect in women. However, men, azzurri is the name and the color of the Italian national football team. Blue for many Italian men is not a color of solace, but of excitement. It is hardly the color of sleep. I mean, when I read through that, I go, I actually believe that. Then I go, no, I don't, because I know the study. And it's fascinating where we can just make up a story that's just absolute. It sounds good, it's brilliant, and it's absolute bullshit. So here's what's cool. If it was true that the color of pills was important to the effect, you'd have thought industry would have bought into that. And they've actually gone and looked at what color pills are actually produced by the industry. And they said, well, let's assume that orange, yellow, and red would be a stimulant, and green and blue and purple would be a sedative, and so on. And they looked at all the products that are out there. And they showed that the color corresponded to the desired effect at most 50%. And in fact, in most cases, it was around a third of the time did the color ever have anything to do with what, if it was a real thing, that it would actually be the color that was that you're trying to get the benefit of it. So they don't even believe it. Because you can imagine if you could somehow get benefit from a different color, you'd do it. So it's really fascinating to go look at beliefs about things. And this is what our group does all the time, and I do all the time, is go, I wonder if what I just heard was true. And when you look into it, often it isn't. And other people have looked at this. The notion that the placebo pill appearance is important is based on very small and weak evidence base. So the bottom line when it comes to the placebo effect, there is likely a placebo effect for some people for a few conditions, but it's nowhere close to 30 to 35%. But I still hear clinicians saying that, and I get why that is. I used to say that. But the placebo group effect is much, much larger than the placebo effect. And what I want to now do is just briefly, just for a few minutes, talk about how can you harness that placebo group and get that around that. And also, how do you use placebo without any ethical issues? So there are some ethical issues of actually using placebo, as you can imagine. I mean, if you don't tell a person, I mean, I think it's very tricky. I'm embarrassed that I actually participated in the Oberkalp problem. But if they find out, you're going to undermine trust or compromise the patient-clinician relationship unless you tell them it's a placebo. So I don't think there's a role for using placebo in not telling the person about that from a clinical care perspective. What's very interesting is there is a huge debate in the research area. I was the associate chair of our clinical research ethics board at UBC for a number of years. And there's a huge debate about whether it's ethical to use placebos in research. There's one group that says you should never use a placebo if you have a proven treatment, like in depression. You should never use placebo. But we decided in our group, and many other groups have come to this decision, that it all hinges on appropriate consent. So if we can do first in human trials where we're giving a medication that no one's ever taken before and they don't have a medical condition, we're just giving it to you to see if anything bad happens, and we're going to pay you for it. If we can do those ethically, I think we can do placebo-controlled trials when we already have an effective treatment. And so we debated this a lot in that group that I worked with, and it was made very clear to me by a lay member who said, if I want to be in a placebo-controlled trial of depression, I can make that decision. Your board doesn't have to make that decision, as long as I know, I'm informed about it, I can make that decision. And so that's how we sort of decided it was okay to use placebo-controlled trials even though we have effective treatment. So that's kind of an interesting approach. So we're talking about the placebo group effect. So how can we enhance that in our care. What's really important, and I've given you some examples of here, of what is the chance that a person will get better or get an effect in the placebo group. And I've given you just some of the numbers that you'd see typically in clinical trials. General anesthesia, as I've talked about before, nobody just falls asleep and they go, yeah, go ahead and do open heart surgery. And that was based on a study of 1. And you can see psychosis or ankylosing spondylitis, maybe 5% get better in the placebo group. And you can see there's a variety of things. Panic disorders, 40. If you get blood pressure changes, depression, menopausal, 25 to 30%. So you know that in that group, about that many people will respond to whatever you do, even if it was nothing. So the way I kind of think about it is, if we have what goes on in the placebo group, let's say we have a treatment that benefits about 10% of people. So the benefit of a drug is about 10% above placebo. And that's one of the examples of that was depression that Mike brought up with using antidepressants. It's about 10% above what goes on in the placebo group. And then if you have a really effective medication, it's about 20% absolute benefit. So if you have a condition for which there is no placebo group effect and they get better, you can almost for sure say it was the medication. So even if it's not that effective in clinical trials, but you give it to a person and they get better, you can go, it's probably the medication. Now, not everyone's going to get better because it doesn't work in that many people. But that's a way to think about it. So if there is no placebo group effect and you give it to someone and they get better, it's almost for sure the medication. Where it gets tricky is when you have to start adding in what goes on in the placebo group. And as it gets bigger and bigger, up to 40%, this is an example of antidepressants. About, as Mike said, about 50 to 60% of people will feel better on an antidepressant at 6 to 8 weeks. But about 40% of those people would have got better in the placebo group. So most people who get better weren't because of the drug. And so you can use that knowledge to go, should I stop it? Should I lower the dose? Should I rethink about it? Should I maybe talk to the patient about, it's great that you've done all these other things, that maybe that's why you're feeling better. So that it's really useful to know where that fits in. And if you're interested about, this is about 20 or 25 different things that you do in primary care, and the magnitude of what goes on in the placebo arm, and the blue arrow is the benefit above placebo. So if you're interested in how effective is sildenafil for ED, you can see the numbers there. How effective are antibiotics for strep throat? And it's nice to know if you don't treat, what's the benefit? And the size of that sort of snake oil thing, which is I'm being a bit rude with that, but the placebo effect, you can see in some conditions, it's a good size of an effect. So if you know what the natural history is of a condition, it really helps you think about whether or not the drug worked or whether we should be using a drug. At least that's the way I think about it. Now that only applies if you're treating a symptom, because none of that applies to preventative treatments like that we talked about for atrial fibrillation or cholesterol, because you'll never know if a preventative treatment works, because you can't know whether or not they would have had a heart attack or stroke or died, because you just can't tell. You might be able to look at the surrogate marker and go, it's changed. And if you remember what I talked about with the surrogate marker, for instance, blood pressure, the placebo group effect of lowering blood pressure in the placebo group is about 30% roughly. So you will get a lowering of blood pressure, likely regression to the mean and all that sort of stuff. But what is useful, and we're going to talk about this more in the course as we go along, is if you are going to use preventative medications, you need to know what's the baseline risk. What's the chance of the person having it if you didn't treat it? We showed you the data for the really high blood pressure, and I think most people, if they could tolerate those medications that they were on, the absolute effect that they saw is probably worthwhile. Where the discussion comes into is people where their lower numbers are, and if you look at this chart and the calculators that we create, the whole point of that is to go, what is your risk? If we don't treat you, where are you? And if we treat you, where do you go to? And this is just examples of atrial fibrillation, and if we treat diabetes, if we treat lipids and blood pressure, where do you start from and where do you go to? And if you don't know those ballpark numbers, it's difficult to make sort of those decisions. And then how do you tell if a drug if it's working for symptoms? This is how you do it. Oh, can I get some sound on my? I'll just go back. Hang on. This is how they did it with the Beverly Hillbillies. Oops.
Being brain, there is no cure for the common cold.
Granny's got one.
I don't believe it.
A hand on the book. It ain't failed in 45 years.
Granny, I apologize. This morning I didn't believe you. Your cold cure really works.
Positively, if you follow directions.
By the way, what are the directions?
Take 1 spoonful of cold cure, eat sensible, get lots of rest, and drink plenty of water.
And in a week or 10 days, your cold will be gone.
A week or 10 days.
That's all it takes.
Ain't failed in 45 years.
And then it's very difficult actually to figure out if something is working. So I'm saying that you can, but it's tricky because everything in life is a vibration. This is the natural fluctuation of pain scores in 25 people with osteoarthritis over 3 months. And they did a variety of different scores that they looked at it. And in this group, the average pain is about 5 out of 10. 20 plus of the 25 people had fluctuations, natural fluctuations greater than 50% of their baseline pain. So NSAIDs, you get about a 15% absolute benefit on top of placebo of about a 30 to 50% reduction in pain. So in this group that has this natural fluctuation of their pain, 4 of them will benefit from the medication. It is really difficult to figure out who that is. And that's why we encourage always re-looking at, do you really need the medication? What happens if you stop the medication? What happens if you lower the dose? Because it's really hard to pick that up. And this I thought was really impressive. And one of the things when you look at clinical research, you always see things when you give something, they look at a whole bunch of patients and you see if a treatment works, you can see, slope goes down. Like in this case, this was looking at cognitive behavioral therapy and different things for depression. And you can see that they looked at a number of people over a number of sessions of getting this treatment. And you can see that they started off with severe depression and on average it went down to moderate or borderline. And you go, oh, I guess both of these things work. And they probably had an effect. That's when you take a whole bunch of people and average them out, this was the variation. That's why clinical practice is so difficult. It's here and it's here and here. How do you even figure that out? So even though something might work, and I've just talked to you about the placebo group, I realize it's tricky because of this. And it's so important to re-look at these things. And we see the same fluctuations in all sorts of conditions, the natural fluctuation in COPD symptoms. And I'm sure you see this in your practice all the time. 50% during the day and during the week. So how do you tell, especially in COPD, Jamie's going to talk about some medications, I'm not going to give it away, but they don't all really work that well. Maybe I just gave it away. Or systolic blood pressure. The variation in systolic blood pressure, there have been suggestions that you need to do 40 blood pressures before and 40 afterwards to be sure that you can pick up about a 5 or 10 millimeter change from a statistical perspective. And I know no one's going to do that, and it's very tricky. And one of the things that, and Bob taught me this, is that the doses of most people are basically wrong. And this is a dose response curve. This is the percent of people who respond or the percent of the response, and it's a log dose, and it's a really important thing to remember. The doses in these books are wrong for most people, and this is the typical dose response curve. And when you see a new medication come on the market, we're talking about only 2 doses being usually studied, and they're usually at the top of that dose response curve. And even if you cut the dose in half, you still don't see much of a change in effect. And so one of the really important things is to realize is that you can adjust in lower doses and often maintain a really useful effect. And I think, again, this is another really important concept to understand when it comes to prescribing. But with antidepressants, this is what the dose response curve looks like. That's what it looks like. So they do have an effect, but it's very tricky, and that's why it's tricky. Put this together, and Mike and Adele Varani and I, we published an article a number of years ago talking about why there is a good argument for starting with much lower doses. And people always say, well, you can't cut pills in a quarter or an eighth. Well, you can. I'm not saying that everyone can do this, but this is how it's done. I always say there's crumbs everywhere. I just to annoy my colleague friends, I just say the pharmacists will do this all for you. They don't worry about it. Yeah. So it can be done. And just so you know, that's mirtazapine cut into eighths. And This is someone doing it for Viagra. And this is, I didn't speed this up. They were just very desperate. So it is possible to very quickly cut Viagra into 16ths. There you go. That was quick, right? There you go. So how can you get all the power of placebo without the deception? Use very low doses. Because if you, you could just use, I'm not talking about homeopathic doses, but just little bits. Well, that's it. We'll get that. We'll chat afterwards. So you get all that placebo group effect and everything by just using a little bit, because you don't have to be deceptive. Patients, and if you tell them about this, they are engaged in the process of finding the best dose for them, because you say, I don't know if this drug's going to work. I don't even know if it's working. I'm glad you're better, but let's try and figure that out. Cost savings can be considerable, and most adverse events can be minimized. And I don't care about any drug interactions. There's almost none that I care about if you use low doses, because if you use a quarter or an eighth of the tablet, it doesn't matter whether you have a drug interaction, because you already started at an incredibly low dose. So I am almost right on time. So we just want to set you up with sort of a premise to consider as you're going through this course, and also in your practice, about how to think about decisions that you make with placebos.